Hello, I'm Eric Topol, Editor-in-Chief of Medscape, and I'm delighted to have with me today Zeke Emanuel, who is the Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. Zeke, welcome.
Nice to be here with you.
No, it's terrific, and we could get into so many topics because clearly you've had a big influence on healthcare policy in the United States with the Affordable Care Act and so many things. But today the topic I thought would be of special interest is the physician shortage. And I wanted to go back to, I think your writings are multiple. There was a notable op-ed in the New York Times back in December 13 with none other than our current FDA Commissioner, Scott Gottlieb. And then more recently, you reacted to a AAMC report that was published in JAMA in print in May with subsequent correspondence that went back and forth, as you might expect, because there's a lot of controversy in September. So why don't you give us like your kind of opening sense about physician shortage in the U.S.?
Well, you know, the interesting thing, Eric, is if you look through history, everyone's always predicting we got this terrible physician shortage. And yes, there are lots of problems, you know, delays in getting an appointment, spot shortages in certain specialties, especially pediatric subspecialties like pediatric GI or pediatric cardiology. But if you look at the issue of primary care doctors, I think the notion of a shortage is greatly exaggerated. And what we initially did, it occurred to me literally one night in a dream. It's like, if how can there be a shortage? Let's just calculate how many doctors we have, how many patients we have, and what the actual, you know, match is. And initially we did it two ways. We said, all right, if you're going to have every doctor have 2,000 patients in their panel, and we have 320 million Americans, how many primary care doctors do you actually need? Let's just do the long division. This isn't a complicated math problem requiring differential equations. And then the other way is, if you imagine we have 1 billion outpatient visits in the United States, and each one is half an hour, how many doctors do you need to take those 1 billion outpatient visits? And again, not a lot of math, it's basic division. And it's a really surprising, we have more than enough primary care docs to satisfy all that. So the question is, why is everyone feeling like there's a shortage? And my intuition is we're just bad at managing that time. And probably bad in two ways. One, we have doctors doing a lot of things that they should never be doing. Filling out paperwork, arranging for tests and treatments that you don't need an MD, at least 3 years of post-MD training to really do. And so we're not maximizing our doctor time. And the second is we have doctors doing a lot of appointments with patients that don't require appointments at all, follow-up visits, and things like that. And so I remember, you know, you're a cardiologist, you probably can tell stories like this as well. But I remember when I was training for becoming a breast oncologist and treating breast cancer patients, and I was told, you know, after women who have early stage breast cancer, you remove the lump, you give them 6 months of chemotherapy, you then bring them back every 3 months to get follow-up. And I'm like, where did that come from? You know, right after you finish the chemotherapy, they probably should be the lowest risk of cancer coming back. Every 3 months sounds like overkill to me. Do we have any data that, so, you know, no data, no evidence that that's the right sort of time sequence, et cetera. And so I think we end up with this general overkill for a lot of sequences. And then there's a lot of minor stuff like women with urinary tract infections, you treat the urinary tract infection. You don't need to see them again. You can just check in by text message or something pretty low tech. So I think there's a lot of this unnecessary use of the physician's time.
Okay. So I understand you're getting at paraprofessional help. You're getting at some of the current technology that we're not using enough of, whether that's things like texting. And I'm sure you would be supportive of telemedicine, virtual visits, that sort of thing. But one of the things that the AAMC report, which they really zoomed in on. They were big on these three things. One is that the aging of the population.
Yeah.
Is big about the aging of doctors and the fact that doctors are half of them are well over 50 or 55 even, and they're retiring, and burnout. They're reducing their effort. And then this whole issue about the lengthy work hours today and how that's just unsustainable. So the AAMC probably has what you would say, not the, oh, by the way, you also underscored that our medical school number has increased from 125 to 145. That's a big
Right.
And our medical trainees have increased almost 30% in recent years. So how do you square away their assertions and your math and views?
Well, first of all, this issue of the aging of the population, we've had an aging of the population for a long time now. And I think, again, one of the issues we've learned is that, yes, the population ages, they have more chronic illness, but the best way of attacking the chronic illness and managing it may not be with more doctor numbers, but with more chronic care coordinators who take responsibility for reaching out to patients. So again, the issue is, yes, we will have more patients with chronic illness, but is the solution there more doctor hours? That's the underlying assumption of the AAMC, and I think that assumption is erroneous. The other issue is we are moving a lot of services out of the hospital, and that is going to require more people. But I'm not sure, again, this is mainly a doctor problem. When you look at the aging of the doctor population, I do think the AMC has a point, which is, a lot of doctors in the older generation, above my age and your age, they used to work like maniacs. My father was like, a 70-hour work week was like normal. And the current generation doesn't want to work so much. But as I point out, we have more doctors now than we've had. And even when you do the math, and being pretty generous on the math, 30-minute primary care appointments, 200 workdays, we're not talking about weekend workdays, not extended hours, 12 slots a day per primary care doctor. Even under very conservative estimates of not overworking the doctor, you got more than enough slots to handle the billion appointments that we're going to have, that we have every year in the outpatient setting. So I just don't think the AAMC's math ever worked out. They always use, docs per thousand population. But that's not the number you want. The number you want is how many visits do we need or have, and can we manage that with the current crop of doctors working at a reasonable pace? Now, many doctors work more than the sort of 12 slots a day that we allocated to them, and that's because they need the money or they want the money of additional appointments. But that's a very different issue than a shortage based upon sheer numbers. That's about how much income doctors want to make.
Right. Now, there's a maldistribution issue, which is a biggie, with one-fifth of the American population in rural areas. And that adding more doctors doesn't seem to be the fix for that, right?
Right. So, if you were an economist, you would say, all right, we got to get supply equal demand, and, we'll just make more docs and we'll force them out of New York City or San Francisco and they'll go to North Dakota. But we know that's garbage. I mean, one of the two main ideas is, first of all, we should be very clear. No country, it's not just the United States, not Canada, not Australia, not other countries with big rural populations, has ever solved the maldistribution of the fact that doctors, highly trained, do not want to relocate to small rural cities. The main reason is, they want a lot of the social amenities that come along with a high socioeconomic status. Those tend to be located in larger urban areas, and getting this very talented pool out into rural areas just is not going to happen unless you literally force them, and we're against forcing doctors. Even places like Canada that sort of coerce doctors require that they train up in rural areas. The moment their indentured servitude is done, they leave. So I don't think more doctors are going to solve that maldistribution problem. And so we need to address it by, more allied healthcare professionals, telemedicine, and other ways of linking the rural population and physicians in more urban centers. And that's especially true for specialty care, right? There just aren't enough. I mean, in here we might have a genuine shortage, but that's of a different kind. There may not be enough pediatric cardiologists or pediatric rheumatologists, but they're never going to be in North Dakota. That's a problem you're only going to solve by sort of changing the amount we reimburse them and linking them when patients need their services in rural areas by telemedicine or MD consults via the web. So I think this rural patient population, it's a hard nut to crack, but it's not going to be solved by training more docs.
Okay, now another metric that is used a lot in this whole story is wait times.
Yeah.
Zeke, that the wait times in places like Boston to see a primary care doctor are more than 6 weeks, and the average is well over 3 weeks for the United States. And the idea is, that's been creeping up, so that's a surefire way of saying we don't have enough doctors. Your thoughts about that?
Yeah, so first of all, it's very interesting. They did look at wait times after Massachusetts expanded access. And a large part of the fear is, look, you're going to add millions of more people. You're not adding doctors to cover millions of more people getting health insurance. Wait times are going to go up. No evidence that was true. I don't know that anyone has seen, despite the fact that we added 22 million Americans through the Affordable Care Act, seen general wait times around the country go up. And wait times is not a function, I don't think, of doctor supply. It's a function of how you manage doctor time. So one of the things that I've mentioned is, I went around the country looking at places that are providing high quality, low cost care and doing a very good job. And one of the things you notice is they have what's called open access scheduling. Between 20 and 50% of the physicians' slots at the start of the day are open and unscheduled, and no patients there, so that patients can walk in. Or patients can call and say, hey, you know what, I've got some free time. Can I get my annual exam or whatever, or see the primary care doctor? And that management style, again, actually, ironically, opens up additional free time in doctors' schedules because you have fewer no-shows where doctors had a patient, but the patient either forgot or something else intervened. So there's a lot of mechanisms you can do to actually reduce that wait time. I noticed that your old institution, the Cleveland Clinic, went to same-day appointments, and I think it was last year, did 1 million same-day appointments. So it's possible to do this open access scheduling, get people in on the same day. And that actually, ironically, because of the no-show issue, can get you increase efficiency and decrease the wait times.
Okay. Now, that brings up the issue of healthcare costs. So, we after the first line item of the 3.4 trillion or whatever it is right now, after the hospitals, it's docs that are the next.
Right.
And the concern that you express would be, well, if we actually increase doctors like the AAMC is ordering up, we're actually going to increase costs. Is that true?
Right. So, economists like to say, supply equals demand. And if we've got this big demand of 1 billion office visits and we've got these long wait times, we need to increase supply and that'll even out. But we also know that in healthcare, supply and demand don't work that way. We have what's called supply-induced demand. That is, how often are you supposed to see a diabetic patient in follow-up? There's no evidence-based guideline. And so you got a lot of doctors chasing diabetic patients. You'll have doctors see more patients and just increase costs with no added benefit. We've seen this over and over again. Florida has very high utilization because they got a lot of doctors down there for the old people, too many doctors given the population, and you end up with very high utilization, very high cost, but no evidence that it leads to better care, and some evidence that it actually leads to worse care because you're giving people unnecessary care. You're giving people inefficiently delivered care. One doctor who practices down there and runs a capitated system and is responsible for total cost of care, he says, what you end up seeing is hospitals that have 70 cardiologists on staff, relatively small community hospitals with 70 cardiologists, and they're doing all sorts of unnecessary catheterizations, putting in pacemakers and other things in marginal cases. And he says, you're just driving cost because you've got this big supply of doctors who need to meet a certain income threshold, and so they end up producing a lot of unnecessary care and just driving up total healthcare costs. That's not a place to be. We made that mistake. Richard Nixon, again, in the 70s thought, just increase the number of medical schools, increase doctors, and we'll bring healthcare costs down. Has exactly the opposite effect. Increase the number of doctors, you will increase healthcare costs because they write prescriptions, they write for services like x-rays and other things. And so that's not a good way of approaching the problem.
Well, you've made a really good argument here that goes against almost every point in the AAMC report. Would you say the AAMC has got a conflict of interest in ranking more doctors?
Well, it is an institution that has talked about, if you go back to their reports for decades, talked about shortage.
Yeah.
Yeah, and one of the reasons is, they do represent medical schools, and medical schools want more. They want to be more of them so that they have increased authority, and they want more slots. But that's a lot of medical schools have actually been shrinking, like the University of Chicago, and I think it's we really do need to be much more critical of their position, and I think it's not just medical schools but also postgraduate training, internship and residencies. Do we need all of those slots? We have a lot of slots, and it's not clear that those slots are geared to the trainees. They're often geared towards, satisfying hospital overnight coverage situations and services. I've always noted that, the places with the few number of trainees, like dermatology or radiation therapy, they don't have a lot of overnight coverage. Places where you have a large number of trainees, it's really about overnight coverage. That is not the way the system ought to work.
Right.
And I think we really need to rethink that, we train not only the doctors we graduate here, but we bring in foreign medical graduates to fill all the residency slots. Question is that a good use of our resources, or ought we to think about overnight coverage in different ways?
Yeah, no, I see your point. And, for the 30 years that I've been a physician, I never heard anything but physician shortage. It's been out there long. And, as you know, it's now projected there could be more than 100,000 shortage of doctors between now and the next 12 years, which seems a little far-fetched now. We've talked a lot about the math and the economics, but we haven't really gotten into the really downtrodden spirit, the deepest depression, morale, as you know, suicides. It's there. What could be done to titrate that, to make things better for physicians? Because they really do care for patients, but they're getting burnout left and right.
So I think we have to look at what's the cause of that burnout. Now, one of the causes undoubtedly is the electronic health record and the way it works. And the question is there a tech solution that can make those electronic healthcare records work better for doctors so they're not so onerous to use and actually don't just add time to doctors? Second thing that I think is really, really important is there are a lot of administrative hassles on doctors, speed bumps, as it were, where the sole purpose is to create hassles so that doctors, it'll add time and effort to doctors, like ordering an MRI or ordering a CT scan. Insurance companies put these burdens in precisely because they want to create hassles for doctors. That's the goal, is to create a impediment to ordering these tests. So I think if we change payment so doctors have more autonomy, they're responsible for the money, but they also have more autonomy in how it's spent. You may actually increase doctor satisfaction rather than decrease doctor satisfaction. I've noted that a lot of orthopedic surgeons report that they're happier once they're under bundle payment because they have more control over how the money's spent. They have more satisfaction. And so one important question I think we don't know the answer to, and before we have the data, and it's an important question of if we pay doctors differently, and so they have more control over the money, are they actually going to be happier? And can you get rid of some of these administrative hassles that they have to go through to actually practice? That would be my hypothesis.
What if we give all doctors a really good salary and there was no incentive to do anything but to take care of their patients? Would that help at all?
It's a good question as to whether its salary would help doctors. Places that have used salary, like the VA, there have been problems with productivity. So I think you need to have a balance, and salary has incentive for people who are driven and passionate, well above, and it's not motivated by money. Now, I don't want to say all doctors are motivated by money, but money does play a role. And so when you salary doctors and there's not that intrinsic motivation, you might end up with low productivity. And I think that's been the experience of places that have done that. So I think a balance between giving doctors autonomy, which I think is really what they want. Let me practice my way. Tell me what the metrics are that you want me to hit. Give me control over the resources. And I think that probably would go a long way to alleviating the burnout. Why was my father, despite working 70 hours a week, so happy? Well, he controlled things. He didn't have that many hassles from insurance companies standing in his way of practicing what he thought was good medicine. And I think that's the place we have to get to.
And he had a tight bond with patients, and he had a lot more time with patients than typically doctors and patients have these days, where a length of a visit is so incredibly short.
Yeah.
So this has been really helpful, Zeke, to get your views. I mean, I think the question that I leave you with is, are you optimistic that things could get better, or are we just kind of stuck where we're in the mud where we are right now? Where are we headed?
No, I'm actually wildly optimistic about the American healthcare system. And the main reason I'm optimistic is, we're a great country. We have a lot of people with great innovations and great entrepreneurial spirit. And we're at this moment. Some of it catalyzed by the Affordable Care Act and many other factors of change in the system. And I think people are trying to drive towards a better performing system. And I think we're going to have a lot of testing of new ideas. Not all of them are going to work. A lot of them are going to fall by the wayside. But I think in the end, where the end I think is going to be 10 or 15 years from now, we're going to have a much better system and probably more doctor satisfaction as a result. So I'm optimistic about the directionality of American healthcare, even though some aspects of it now look like they're probably not doing too well.
Right. Well, that's really, that sanguine outlook is much appreciated. I'm sure the folks that are listening and watching this will feel good about that. So, Zeke, I want to thank you. Really great to have you on Medscape to talk about this and get your views, and look forward to watching all the work you're doing in medical ethics, oncology, healthcare policy, and the likes, all that, to keep up the good stuff. And we'll be keeping in touch with you to hopefully get you back again. Thanks a lot.
Good. Thank you very much, Eric. It was a pleasure.